Good morning. I hope you had a good holiday. And today we'll continue our cycle of lectures according to the stomatology of maxillofacial surgery. And topic of our lecture today is maxillofacial injuries. Since immemorial soft tissue injuries to face have been documented in literature and even depicted in sculptures reflecting the image of society. In polytrauma, the face may be involved or there may be isolated injury to the face. The face consists of several organs and aesthetic units. The final outcome depends on the initial wound care and primary repair. Disfigurement following trauma becomes a social stigma and had a gross detrimental effect on the personality and the future of the victim. Injuries of maxillofacial area or region can be classified by next classification. Soft tissue injury to the face and intraoral structures, including lacerations, abrasions, contusions, avulsion, burns, puncture, penetrations, and others. Face fractures to any of facial bones, nasal, zygomatic, maxillary, mandible, teeth injuries, impaction, subluxation, avulsion, and fractures of the teeth and alveolar bone. And the last point of this classification is a temporomandibular joint dislocation. Various types of injuries occur depending on the etiology and mechanism of injuries. Casual factors of these injuries include road traffic accidents, interpersonal violence, homicide injuries, domestic injuries or accidents, falls, gunshots, industrial accidents, sport-related injuries, animal injuries, and iatrogenic injuries. They can affect the skin, subcutaneous tissue, muscle, fat, nerves, blood vessels, liver glands, and eyes. Quite oftentimes, depending on the force of impact, soft tissue injuries are associated with regional bone injuries, sinus injuries, as well as varying levels of the brain injury. In the next slide, you can see different types of wounds as injuries of soft tissues. And of course, they can be classified not only as a soft tissues injuries, and for example, open and closed, acute and chronic. Let's see, what does it mean, acute or chronic wounds? And acute wounds is expected to progress through the phases of normal healing, resulting in the closure of the wound. And chronic are wounds that have failed to progress through the normal stages of healing and therefore enter a state of pathologic inflammation. Open and closed wounds. What does it mean? The skin is cracked open, leaving the underlying tissue exposed to the outside environment, which makes it more vulnerable to the bleeding and infection. In closed wounds, the skin is intact and the underlying tissue is not directly exposed to the outside world. Facial injuries themselves are rarely life-threatening but indicators of energy of injury. The types of soft tissue injuries which are classified depending on their course includes abrasions, tattoos, simple or complex lacerations with loss of tissue, avulsions, bites, burns, contusions, and all of them you can see on this slide. And here you can see differences between open and closed wounds. Last two wounds, contusion and hematoma, or underlying hemorrhage, it's a closed wounds, of course. And previous all wounds, they are open wounds. And let's see, what is abrasion? Abrasion is superficial epithelial wounds caused by frictional scraping forces. When extensive, they may be associated with fluid loss. There's usually not of bleeding, but the wound needs to be scrubbed and cleaned to avoid infection, and superficial foreign bodies should be removed to avoid unsightly tattooing. And laceration. Laceration is the deep cut or tearing of the skin. Accident with knife, tools, and machinery are frequent causes of laceration. In the case of deep laceration, bleeding can be rapid and extensive. And on this slide, you can see abrasions of the face, and we can see that there are not so severe bleeding, but we can see the blood and even crust on the healing of abrasion. And what are the difference between abrasion and all other types of open wounds? That abrasion, it's a superficial wound, and it's not with the damage of basal membrane, and that means for us as the maxillofacial surgeons that abrasion will heal without any scars. It will heal with a full regeneration of all layers of the skin of the dermis, and we won't see a scar after the wound healing process. And on other open wounds, of course, after wound healing process, we'll see different types of scar. It can be normal scar, it can be invisible scar, but there would be a scar. And here on this slide, you can see different lacerated wounds, and it's a surgical laceration or surgical incision. And of course, we can understand if it's a surgical incision, it will be clean wound. And about this classification, we'll talk a little bit later. Surgical incisions cause minimal tissue damage. They are made with precision in environment where septic and antiseptic techniques reduce the risk of infection with the best of the instruments and the facility to control hemostasis. Penetrating trauma may involve minimal damage to skin and connective tissue, though deep damage to vessels, nerves, and internal organs may occur. And bite wounds. Bite wounds may be caused by the animals, for example, dog, cat, snake, or rodent human. It's important to determine the course of the bite wound because different bacteria or toxins may be present depending on their source. Puncture. Puncture is a small hole caused by a long pointy object such as a nail or needle. Sometimes a bullet can cause a punctured wound. Avulsion. Avulsion is a partial or complete tearing away of the skin and the tissue beneath. Avulsion usually occur during violent accidents such as body crushing accidents, explosions, and gunshots. They bleed heavily and rapidly. And on this on this side, you can see puncture and avulsion, and of course you can see that puncture can be a small hole of the superficial skin, and that doesn't mean that it's most easily and uncompleted wound. Of course, punctured wound can be penetrated from it can penetrate, for example, maxillary sinuses on this photo you can see, and it can penetrate oral cavity, nasal cavity, and even major salivary glands. And avulsion. There may be ecchymosis, edema, subconjunctival hemorrhage, crepitus, hyperesthesia, evidence of facial nerve palsy, inadequate excursion of the muscle of the expression and mastication, wound with or without exposed vital structures and fractures. Usually, horizontal injury across the face is likely to damage more vital structure than in the vertical injury, as it passes through more numbers of zones. In deep injury, it's necessary to evaluate communication with oral cavity and other cavities, as said, maxillary or frontal sinus and glands. Contusions. It's another type of wound. It's a closed wound, and let's see I have no this contusion, but okay, let's see on this slide. Contusions are caused by more extensive tissue trauma after severe blunt or blast trauma. The overlying skin may seem to be intact, but later become non-viable. Larger hematomas under the skin or in the muscle may coexist. If they're superficial and fluctuant, they can be evacuated with overlying necrosed skin. Ultrasound scanning or magnetic resonance imaging may help to define a hematoma amenable to evacuation. Extensive contusion may lead to infection. The risk of infection in traumatic wounds is reduced by adequate wound cleansing and debridement with the removal of any non-viable tissue and foreign material. If severe contamination is present, a broad-spectrum antibiotic prophylaxis is indicated and should be extended as a specific therapy as recommended for surgical wounds that are classed as dirty or when there are early signs of infection. Traumatic wounds need tetanus prophylaxis. These wounds, dirty wounds, need extensive debridement down to the available tissue and should be left open until healthy granulation tissue has formed. Repeated debridement may be necessary. After debridement, delayed primary or secondary suturing may be done with or without reconstructive surgery. Alternatively, if the combination of the wound contraction and epithelialization will leave an acceptable cosmetic appearance, a wound may be left to heal by secondary intention. Human and animal bites are traditionally managed in this way, but primary closure can be done after wound debridement and excision of non-viable tissue. And here let's have several words about clean and infected wounds. Clean wounds, of course, most of clean wounds, it's surgical wounds because they are made in environment which are with aseptic and antiseptics and with special clean instruments. But if it's infected wounds, it may be, for example, acute wounds due to falls, different acute open wounds. They are infected wounds, primary infected wounds, and in sometimes, of course, we can suture them after special debridement, as I said. But if it's a primary infected wound, for example, if it's a wounds after incision or drainage due to some abscess of lemon, about it we talked on previous lecture. Of course, it's a primary infected wounds, and we can't suture them. We have to stay them to heal with or by secondary intention without any suturing. And about the wound healing process, we'll talk now. Stages of wound healing process. And here you can see three main stages, and some literature you find 4 stages because hemostatic phase or stage they include in the wound healing process. About hemostatic, we have no time, unfortunately, to talk, but we'll talk about it on our practice. Different ways of stop bleeding. And inflammatory phase. From the beginning to the 4th days, it's inflammatory phase, and it occurs immediately after injury. Tissue damage initially causes the disruption of vascular vessels and extravasation, followed by the producing of temporary platelet plaque and fibrin clot, which stops bleeding and activates subsequent infiltrate inflammatory cells, causing heat, redness, pain, swelling, and loss of function. Wound exudates may be present, and this is also a normal body response to injury. Reconstructive phase, or next, during the proliferative phase, which occurs several days after the tissue damage, we'll find reconstruction phase, keratinocytes and then cells proliferate and migrate to the wound, resulting in reepithelialization and angiogenesis. The wound will become smaller and as it heals. Maturation phase from 24th day to the 1 year. Finally, in the remodeling phase, some fibroblasts are stimulated by macrophages to differentiate into myofibroblasts, causing wound construction. During this phase, production of the extracellular matrix, including collagen, proteoglycan, and fibronectin, is increased, which results in formation of mature scar. All of these events require the orchestrated efforts of different types of cells. Failure in any of these phases of the wound healing process can lead to the chronic wounds, hypertrophic scars, and or wound-related tumor formations. And here you can see on this slide different abnormal scars, hypertrophic, atrophic, and normal. Types of wound healing process. It's a primary intention and secondary intention. In some literature, we find delayed primary intention, but let's talk about all of them. Primary intention. The wound edges are held together by artificial means such as sutures, staples, tapes, and tissue glue. There is minimal tissue loss and the wounds heal with minimal scarring. Most clean surgical wounds and recent traumatic injuries are managed by primary closure. Delayed primary intention when the wound is infected or require more thorough intensive cleaning or debridement prior to the primary closure, usually from third to 7th day later. May be used for traumatic wounds or contaminated surgical wounds. And secondary intention, spontaneous wound healing occurs through the process of granulation, contraction, and epithelialization, results in the scar formation and used as a method of healing for pressure acute surgical or traumatic wounds, for example, a sinus drained abscess, skin tear, or superficial laceration. Facial wounds without additional injuries are repaired as soon as possible. In major trauma, while instituting the resuscitative measures, the wound may be dealt after 4 to 6 hours. Laceration will require straightforward closure. In cases of loss of tissue, dimensional and three-dimensional measurement of the wound is taken to assess the size of the tissue required to cover. In acute wounds, all the devitalized tissue are debrided conservatively. A search for foreign material is undertaken, preventing prolonged inflammatory response and infection. Many of procedures can be performed under the local anesthesia. However, substantial number of cases may need general anesthesia. The choice of reconstruction depends upon the localization or location of the defect, dimension, and tissue constituents. Well-chosen reconstruction performed as an acute situation may deteriorate because of contamination of the traumatic fluid or constitute soft tissue included in the reconstructive design. Few may need free tissue transfer. Skin grafts and flaps. We can use a few words about it. Skin grafts is a removal of partial or full thickness segment of epidermis and dermis. And of course, we can use full thickness skin grafts and split skin grafts in different ways. But here you can see full thickness skin grafts with the blood supply and transplanted it to another site to speed up healing and reduce the risk of infection. And flaps is a surgical reconstruction of skin and underlying structures to repair a wound. Flaps are named according to their tissue components and may include anastomosis of blood supply to vessels attached to or at the affected sites. And here on this side you can see meshed skin to cover the large wound, and of course in the face it's rare when we use meshed skin because of aesthetics units, but sometimes of course in large defects we have to use different skin grafts and flaps. And on this slide you can see rotundum flap on the upper photos, and usually it's a reconstruction of nasal tip due to maybe some cancer or due to the trauma. And in the lower part of the slide you can see triangle flaps or reversible flaps, when we can use it in order to close rotundum defects of the face. Dental injuries, it's the next point of our classification, and injuries to the maxillofacial area commonly associated with the dental alveolar injuries. Careful inspection of the dentition and gingival mucosa will identify most dental injuries, account for all of the patient's teeth. Once teeth may be displaced into the adjustment soft tissue to become aspirated, swallowed, or simply lost on the scene. In sometimes radiographs may be necessary to locate missing teeth. Examination of the oral cavity begins with inspection. We have to remove all blood and debris from the oral cavity prior to the examination, then record the location and size of soft tissue injuries. The presence of an empty socket may indicate complete avulsion of the tooth. Gingival bleeding may occur as a result of laceration from the underlying fracture. Each tooth is then palpated to evaluate the mobility. Abnormal mobility may indicate a subluxation or non-displaced injury, or luxation or displaced injury of the involved tooth. Perform percussion of each tooth. Sensitivity elicited by percussion suggests a consumption injury in which the tooth generally is not mobile or displaced but has sustained an injury. Fractures of teeth can be classified as crown fractures involving the portion of the tooth above the gingival surface, root fractures, and as we can understand, involving the portion of the tooth below the gingival mucosa. And the Ellis classification system commonly is used to describe crown fractures. Ellis first fractures involve the enamel only, and the tooth appears normal in color but has an obvious irregularity in the enamel surface. Ellis second fracture involves the enamel and the dentin. The fractured surface may reveal a yellow center from exposed dentin surrounded by enamel. Also, the patient may complain of the pain or sensitivity of the involved tooth. And the Ellis third fracture involved the enamel, dentin, and pulp. Bleeding from the pulp may be observed. Bacterial contamination of the pulp can result in necrosis of pulp, necessitating endodontic therapy. Root fractures represent till 7% of dental alveolar trauma in permanent teeth. Suspect injury of the root when bleeding from the gingival sulcus is observed. However, these injuries are best detected with radiographs. And on this slide, you can see different root fractures. It can be isolated root fractures, like on intraoral X-ray, and I show it by red arrow, and it can be crown root fractures involving both corneal and intraalveolar part of the tooth, and you can see it on X-ray or on the photo, and we can see bleeding and a broken root, a fracture of the crown part and the root part. And what have we do with these teeth? Now, of course, if it's on the crown part of fractures like on these photos, we can easily drill and then fill it, even without pulp extraction. If it's enamel, dentin, and pulp fractures, or Ellis third classification, of course, we have to extract the pulp because it's infected pulp and necrotized part of the pulp should be extracted, and then root canal treatment and restoration of the crown part of the tooth. And if it's a vertical fracture of the tooth, of course, we have to extract in all cases these tooth. If it's a horizontal fracture of the root, for example, as you can see on this X-ray, it depends on the level of the fracture. If we'll divide only by visual examination all root on three parts, and if the fracture is on the upper part near to the apex or to the root endings, of course we can save the tooth. And I hope you remember the surgical treatment of chronic strictly periodontitis. We can resect a part of the root or do resection of the apex of the root, and to save the tooth because attachment of the tooth of third of the tooth will be enough for chewing. But if it's a fracture of the root part in the middle or near to the crown part, of course we have to extract this root because attachment is not sufficient. Temporomandibular joint dislocation. In order to understand the temporomandibular joint dislocation, we have to know anatomical structure of the mandible. And the lower portion of the face is dominated by the largest and strongest facial bones, the mandible. And before it, I should say, of course, that usually we divide all the face into the three portions: upper, middle, and lower portions. Upper portion, it's a frontal bone. Middle portion, it's all our face, it's a maxillo-nasal bones and zygomatic bones. And lower portion of the face, it's hardest and strongest bone of the face, it's a mandible. Mandible is made up of the body and the two rami. The junction between body and ramus is referred to as an angle. The most anterior portion of the body is the symphysis. The body serves as attachment for all of the lower teeth. The mental foramen containing the mental nerve and artery is located in anterior portion of the body. The superior portion of the ramus contains of the condylar process and coronoid process, which are separated by the mandibular notch. The condylar process articulates with the glenoid fossa of the temporal bone to form temporomandibular joint. Once more, temporomandibular joint consists of condylar process and glenoid fossa of temporal bone. Temporomandibular joint dislocation. Dislocation of the temporomandibular joint may be caused by trauma, generally by a blow to a chin while the mouth is open. It also may occur from a non-traumatic mechanism such as the yawning, laughing, laryngoscopy, or prolonged dental work. Temporomandibular joint is a hinge and sliding joint. During the normal mouth opening, the condyle rotates and translates forward to the area of the temporal eminence. In the dislocation, the condylar head slides farther forward and becomes locked anterior to the temporal eminence. Trismus and spasms of masticator muscle prevent the condyle from sliding back. Temporomandibular joint dislocation may occur in a unilateral and bilateral pattern. Obtaining a history from a patient with the temporomandibular dislocation can be difficult because they may have a difficulty with speaking. However, any history of trauma or incident event should be sought. The possibility of dystonic reaction should be considered. Temporomandibular joint dislocation may be a chronic problem in some patients, so it's important to ask about any prior occurrences. Temporomandibular joint dislocation usually is event on physical examination. The patient will present with a difficulty talking and inability to close the anterior teeth, or even inability of movement of the jaw. Patient with bilateral temporomandibular joint dislocations will present with symmetric open anterior bite. In a unilateral dislocation, the jaw will be deviated to the unaffected side. Palpation of the temporomandibular joint area may reveal the condylar head in an abnormal position below the zygomatic arch. If the dislocation resulted from the trauma, the remainder of the mandible, intraoral, and facial areas should be inspected carefully and palpated to assess for any accompanying fractures. Most commonly, reduction of temporomandibular joint dislocation is performed via the intraoral route. And this reduction you can see on the photo on this slide. To prevent trauma, the doctor's finger should be gloved with the thick gauze taped securely on the both thumbs. To ensure adequate leverage, the patient should be positioned so that the mandible is below the level of the proxioneous elbows. We should place our fingers, or our thumbs, sorry, upon the lower molars and on the ridge of the mandible intraorally, posterior the mandible molars. I'll repeat that the thumbs should be wrapped externally around the mandibles. Apply firm, slow, and steady pressure in a downward and posterior direction. If bilateral reduction is not possible, reduction may be done on side at a time. Reduction attempts that require excessive force should be aborted because they may cause iatrogenic fracture of the mandible condyles. The patient may wear a soft neck brace and warm compress may be placed on the temporomandibular joint for comfort. The patient should be instructed to avoid extreme opening of the mouth, such as may occur during yawning, laughing, and dental procedures. Pain relief may be achieved with non-steroidal anti-inflammatory drugs. Patients with chronic dislocation may benefit from the use of Bartlett bandage as elastic bandage that is wrapped around the bottom of the mandible and over the top of the head to prevent excessive jaw opening. If you have any questions, you may ask in our chat. If everything is understandable, let's see on this photo, on this scheme. It's dividing of the face into portions or into portions. Frontal, as I said, frontal bone, it's the upper portion of the face, maxilla, zygomatic bone, nasal bones, and temporal bone, it's middle portion of the face, and mandible, it's a lower portion of the face. And of course, I showed you this scheme in order to understand about what bones fractures we'll talk now. And first, we'll talk about mandible fractures. Facial mandible can be classified under the various mandible fractures can be classified under the various aspects such as the location, type, completeness, number, and course of the fracture line. Characterization by the anatomic signs involved in commonly the initial stage in the classification process. Mandible is the largest and main bone of the lower part of the face. And here on this slide you can see anatomical structure of the mandible, and of course it's a classification, anatomical classification of the fractures of the mandible. Symphysis, body, angle of the mandible, ramus of the mandible, and three processes: condylar, coronoid, and alveolar process. According to the character of the classification, we can classify all fractures according to the fractures with dislocation and fractures without dislocation. And on this X-ray, it's extraoral X-ray and photograph, you can see fractures without dislocation, and I show it by arrow, by black arrow. We can't see any dislocation, but we can see lines of fractures. And by red arrows, you can see fractures with dislocation. It's a photo of our patient with a fracture with dislocation, and we can see dislocation by visual examination. A symptom of this step, it looks like a step on the occlusion of surface of the teeth, and we can guess that opposite side or lower border of the mandible will be with this step too, and we can easily palpate it. And on X-ray, on extraoral X-ray, we can see this dislocation too. According to the number, single, double, multiple, unilateral, and bilateral. And what does it mean? It's a different classification, single, double, and multiple. It's according to the number or amount of the lines of the fracture. And unilateral and bilateral, it's understandable too, according to the side of the fracture. It can be single, for example, and unilateral. That means, and I prepared you X-ray. Here you can see, for example, double unilateral. That means that we can see two lines of the fracture on one side of the mandible, on the right or on the left side. We can see two lines of the fracture, and of course, on the diagnose, we should write the position, anatomical position of the fractures line. Single bilateral, what does it mean? We can find one line of the fracture on both sides, and it will be bilateral. In amount, we can see two lines of the fracture, but on one side, one line, and it can be with dislocation or without dislocation, and you can, I hope, easily see it on CT and on X-ray. And this X-ray, it's a orthopantomograph or OPTG multiple fracture. Yeah, it's the next point of this classification. We can find a lot of lines of fracture, and we have to sign them all by anatomical location of this fracture, but it will be multiple fractures. And of course, the cause or reason of this fracture, usually it's a gunshots or some blasts. Of course, this classification, it's not all classification. There are a lot of different classification of mandible fracture, but it will be enough for us in order to understand differences between clinical characteristics of mandible fractures. Clinical assessment. Complete history trauma should be obtained after cardiopulmonary and vital neurological function of the patient are stabilized. The mandible should be carefully evaluated by extraoral palpation. Mandible contours such as the ramus, lateral, and inferior borders, and symphysis and parasymphysis area should be checked, and continuity of the mandible bone should be noted. Movements of the fragments can be evaluated by bimanual palpation. Ecchymosis and crepitation should be assessed. Check mandibular movements. Deviation and restriction of movements should be evaluated considering condylar trauma. Also, the condylar head should be evaluated by palpation to check if it's in articular fossa or not. Mucosal laceration, oral bleeding, ecchymosis, and sublingual hematomas should be checked by intraoral inspection. Rule out fresh oral bleeding in the sublingual space or bilateral symphysis fracture to secure airway, especially for anticoagulant drug users. Examination of the occlusion, including loose, fractured, or missed teeth, should be performed carefully. A screening maneuver for mandibular fractures is a tongue blade test. Most patients with mandibular fracture will not be able to exert much bite force because of the pain. The masseters are considered the strongest muscle in the body, and normal adults can easily blend and break the tongue blade, which is clenched between their teeth. Patients with mandible fracture are unable to perform this task without extreme discomfort, and difficultly performing this task should be considered the high risk for the mandible fracture. And of course, this tongue blade test, it's a evaluation of the mandible fracture, if, for example, if we have to transportate our patient and we have to notice if there any fracture or if it's a simple uh, soft tissue injury, for example, or trauma close to wounds, for example. And in order to understand if there any fracture in the place of the car crash, for example, we can use this thumb blade test. But in order to do this test, we have to have thumb blade. In Russian classification and in Russian literature, you won't find this thumb blade test, but we have the same test, and most easily you can do it without any thumb blades. We have to press by thumb on the chin of the mandible or on the symphysis of the mandible, easily to press, and deviation of the pressure or of the force of this pressure will go to the all of the mandible, and of course the patient will feel the pain, especially at that area or where we can find the fracture. If it's only the trauma of soft tissue, patient won't feel extremely acute pain of specific or particular in some area. It will feel a pain of all of the jaw. In most cases, clinical examination cannot be sufficient to intensively evaluate the entire fractures line, displayed small fragments, root fractures of the teeth, and neighboring anatomical structures. Of course, we have to do plain films of PTG, and computed tomography can provide additional data about the fracture for better evaluation of the patient. The patient mm, and um, about treatment of the mandible fractures. The main principles of treatment, of course, it's a reduction and immobilization. The purpose of fracture treatment is to return the mechanical strength of the fracture site to its healthy site and to achieve the improvement of the masticatory muscles' normal function. Fractures that are not displaced and exhibit no occlusional changes may be able to non-surgical management, but the majority of mandible fractures will require stabilization for satisfactory healing and to restore pre-traumatic maxillomandibular orientation. Various treatment strategies have been described and vary widely depending on the fracture location and the surgeon's performance. The patient's demographic comorbidities, dentition, and fracture characterization will all influence the choice of fixation by the treating surgeon. The first stage of treatment is to return fracture parts to their normal anatomical position or reduction. The second stage is the fixation of the parts of their normal anatomical position or immobilization. If the history of the trauma doesn't exceed 8-10 days, the fixation of the fractures can be done manually. In order to control the pain, local anesthesia can be applied. Fractures of the mandible can be treated either with open methods or closed methods, or open reduction and closed reduction. And let's see what are the differences between these methods of reduction. Anatomical restoration of the fragments without visualization the fracture line is called closed reduction. In closed reduction, both tooth bone and bone-bone stabilization can be used to immobilize fixation or immobilize fracture to obtain correct maxillomandibular relation, which is called intramaxillary fixation or maxillomandibular fixation. It's usually basis of closed methods. Intramaxillary fixation is fixing the mandible and maxilla together when the teeth are occluded, so the patient cannot open his or her mouth for the certain period to allow secondary healing of the bone fracture. In closed methods, arch bars are often used with the ligature wires. The wire is passed through the intradental gap. One end of the wire is passed under the arch bar and the other is passed over the arch bar. With fine tip tool, the wire is placed under the cingulum of the tooth and the wire is bent to secure the arch bar to the tooth. The most important disadvantage of closed therapy is continuation of intramaxillary fixation, not less than 4 to 6 weeks. This may lead to undernourishment of the patient and weight loss. Also, the patient must be informed about the oral hygiene due to the difficulty in cleaning the teeth under the intramaxillary fixation. Non-displaced favorable fracture and grossly comminuted fractures with soft tissue lost can be candidate of closed reduction. Maxillomandibular fixation can be performed with the use of Eric arch bars, IV loops, hybrid arch bars, intramaxillary fixation screws, circummandibular and piriform wiring, and orthodontic brackets with hooks. And here on these slides with closed reduction, we can see special splints with special ribbon fixation for intramaxillary fixation, and you can see deviation of these ribbons, and we put it especially not straight from lower part to the upper hook, from lower hook to the upper hook. We can use different deviation of these ribbons in order to give contour force to the muscles which are the reason of dislocation of the bone parts or broken fragments of the mandible. Of course, the course of dislocation of these parts of the broken bone, it's muscles, masticatory muscles, and in order to do close reduction, we have to give opposite force to these muscles in order to dislocate it in anatomical right position. And of course, after putting these intramaxillary fixation or splints, the hooks, they can be individual, not individual. After putting this fixation of these splints, we have to do control X-ray in order to be sure that our close reduction is successful. If it's successful, we have to stay it not less than 4 weeks in order to start wound healing process or bone healing process. If it's fracture with dislocation or maybe some difficult fractures, multiple fractures, of course, we can stay these braces, or not braces, sorry, splints more than 4 weeks to even 6 weeks. And our patient have to eat only liquid foods because their mouth is closed and they can't open the mouth. And the next type of fixation or reduction, sorry, it's an open reduction. It can be in the one moment reduction and fixation because we can use, as you can see, special mini plates. And let's see, what is open reduction? Open reduction is preferred when closed treatment is not possible or has failed. In open reduction, there is a surgical approach to the fracture and the fracture segments are repositioned to their anatomical position. This is followed by the fixation step. Fixation can be either rigid or semi-rigid in open reduction. Compression plates and biocortical screws are used in rigid fixation. While this is a reliable method and allows the patient to quickly return to their daily function. Semi-rigid fixation is performed using mini plates. These smaller plates are placed on the stressed areas in the fracture. It's thought that micro movements caused by semi-rigid fixation have a positive effect on the callus formation. Monocortical screws are used so that anatomical structures are preserved. It may be possible to perform even under local anesthesia and with an intraoral approach. Occasionally, occlusion can be obtained using intra-maxillary fixation and elasticity. The patient is given a soft diet during semi-rigid fixation. It's not mandatory to remove the plates after healing. And on this slide, you can see orthopontomograph with uh, open reduction and closed reduction. Upper one, it's with closed reduction. We can see spleens and intramaxillary fixation, and in lower OPTG, we can see at one moment closed reduction and open reduction, and we can guess that maybe closed reduction was unsuccessful, and we have to do open reduction like a next step of the treatment. And on the photos, you can see spleens, different types of spleens. It's a common spleens, upper one, or not individual, and lower one, it's individual spleens of Tigerstadt with special hooks. What does it mean individual? We do the spleens for each patient due to their uh, this amount spaces inside the mouth, maybe some other deformities when we can't use standard spleens. And here you can see open reduction methods. It's many plates with special screws, and approach can be intraoral and extraoral. Of course, usually we use the intraoral approach in order to save patients' appearance without any scars. But in some cases, when it's impossible for the surgeon to do intraoral approach, we have to use extraoral approach, and usually we do it in a 1 or 1.5 centimeter under the lower jaw margin. And on this slide, you can see external type of fixation. We can use special apparatus in order for external fixation. And as you can understand, usually indication for external type of fixation, it's a multiple fracture with a lot of fragments of the mandible. We can't extract them, and we of course want to save it, and we have to save it, and we can save it only by external type of fixation with a lot of points of fixation. Of course, this method we use rarely, and disadvantage of this method of fixation, it's a necrosis of soft tissues, because you can see that these sharp metal objects we have put through the skin, subcutaneous skin and muscles to the bone fragments in order to stabilize it and fixate it. Let's have a break, 5 minutes of break, and then we'll continue. Anatomy of the nose. Um, Nose is made up of the bony and cartilaginous framework. The bony nasal pyramid consists of the paired nasal bones and the frontal process of the maxilla bilaterally. Cartilaginous structures include the upper and lower lateral cartilages and the septum. Both of these frameworks are susceptible to the fracture. Injuries of the nose are relatively common. In cases of the facial trauma, nasal fractures account for approximately 40% of the bone injuries. Fights and sport injuries account for most nasal fractures in adults, followed by the force and vehicle crashes. Nasal fractures may occur in the isolation or in the association with other facial injuries. And what about classification? Um, 5 types of nasal fractures. Nasal fractures can be classified as a scale depicting the severity of the injury, and isolated nasal fractures is usually caused by low velocity trauma. If the nose is fractured by high velocity trauma, then facial fractures are often unaccompanied. And according to the classification, first type it's a soft tissue fractures, restricted injury restricted to the soft tissue. Second and A and B, it's a non-displaced fracture. Second A is a unilateral, and second B it's a bilateral non-displaced fracture. Fourth type, it's a displaced fracture. And fourth and fifth types, it's closed and open comminuted fractures of the nose. And of course, our classification is fractures with dislocation and without dislocation. Simple classification will talk about clinical features by this classification. Deformity of the nose usually will be evident when a nasal fracture has occurred. However, epistaxis without obvious nasal deformity may be the only clinical findings in some nasal fractures. The relative is by which epistaxis can occur with the minor trauma is explained by the dense and redundant vascular network that supplies the nose. This plexus, known as the Kehlbach's area, is responsible for the vast majority of the normal epistaxis. However, the bleeding as a result of nasal fracture usually originates from the other location within the nose. Edema and ecchymosis of the nose and periorbital structures ordinarily will be present, particularly if examination is performed more than several hours after the injury. Palpation of the nasal structures should be done to elicit any crepitus, deformity of the nasal bones, dentation, or irregularity of the nasal bone. In the case of dislocation, orbital reinstem of present. Uncommon findings such as cerebrospinal fluid leak, pausing in the clear rhinorrhea, subcutaneous emphysema, mental status changes, new malocclusion, or limited extraoral movement should be prompt, immediate, suspiciously referral. This may indicate association basal skull fracture or mid-face leaf fracture. And here, let's stop on the clinical evaluation and clinical picture of our patient with nasal bone fractures. Of course, it's a deformity and swelling of the nose, even if there is a fracture without dislocation. Ecchymosis, epistaxis. Now, what does it mean? I hope you know that ecchymosis, it's a subconjectural hemorrhage, and epistaxis, it's a nasal bleeding. The shape of the nose and the arm movement. According to the nasal bone fracture with dislocation. About cerebrospinal fluid leak from the nose, and how can we understand that it's a CSF leaking inside the epistaxis? How can we understand? Because it's too difficult by visual examination. Of course, we can do lab investigation, but as I said, for the mandible fractures, for example, if it's a car crash or some other accidents, and you are a doctor, you have to understand how to transport this patient to the hospital. If it's a simple nasal fracture, you can sit this a patient to the car or to the ambulance and transport it without any difficulties. But if it's a nasal fracture associated with a basal skull base of this cranium, for example, fractures, and it's not typical epistaxis, how can we understand that it's sad? It's a CSF. About it, we'll talk in our practices and about the differences due to the ecchymosis and what is typical ecchymosis and what is raccoon eyes. Are they the same or it's a different symptoms? And pay attention and find it in the literature. According to the nasal fracture treatment, it will be the same principles. It will be the same as for mandible fractures. It's a reduction or replacement if it's a fracture with dislocation, and then fixation. Reduction can be open and closed, the same. And what is open and closed principles of reduction? The closed reduction is non-surgical reduction when we can see the line of the fracture, the line of the dislocation of fragments of the bone. And open reduction, of course, we can see it by visual examination and then do reduction and fixation. In the acute phase of the nasal bone fracture, the simple application of the ice and analgesia may be suitable. Most severe facial trauma will require assessment and stabilization of the airway. Reduction of the nasal fractures is not always required. If there is no fracture or no deformity of the patient is happy to live without minor deformity, then nothing further need to be done. If swelling interferes with an adequate examination, the patient should be reassessed after 5 to 7 days. Manipulation should never be delayed more than 2 weeks following injury, and as the nasal bones heal and fixate, manipulation at this stage will be difficult or impossible. After this time, only a formal septal rhinoplasty will be possible. Local anesthetic reduction. The local anesthesia injection is infiltrating along the lateral aspects of the nasal bone, the premaxilla, and intranasally along the septum. Key injections to the intraorbital nerve, intracochlear, and sixth branch of trigeminal nerve can provide additional fluid blocks. In the most straightforward approach with success rate to 19%, it's usually reserved for simple non-comminuted fractures. The fundamental principle is to apply a force opposite to the vector of trauma to achieve fracture reduction. Under the local anesthesia, depressed segments of the nasal bone can be reduced using the elevator. Alternatively, Wolfman's forceps can be inserted into the nasal cavity and rotated laterally to out fracture of the bone. All nasal bone reduction should bear dorsal splint for 7 days. Not only does it help hold bone in place, but remind the patient and others around them to be careful as the bone can quite easily displace again. Most closed reduction don't require internal splints, but they have been used in comminuted fracture, septal dislocation, and with inwardly collapsing nasal bones. Open reduction fracture that cannot be reduced by closely techniques are candidates for formal open reduction via the open septal rhinoplasty, or maybe unsuccessful closed reduction. Of course, we have to do open reduction. Sometimes the injuries between bones and cartilages may be complex, and fixing one without the other will lead to the patient with the open nasal breathing issues. The greater exposure and direct visualization is a major benefit over the close reduction. One may need to wait 4 to 6 months after the initial injury to allow tissue to settle before formal open septal rhinoplasty can be considered. And of course, as all traumas and surgical treatment, there can be complications, and complication can be septal hematoma as a result of trauma. And in some cases, we have to drainage this hematoma, but not in all cases. We have to do it only even if it's encapsulated and maybe inflamed. Septal abscess as a result of infection of septal hematoma. Avascular necrosis of nasal septal cartilage leading to the sudden deformity is due to usually to the multiple accumulated fractures of the nasal bones, and these small pieces of the nasal septal cartilage or lateral cartilage or even nasal bones can lead to the necrosis. Nasal obstruction. We can use or prescribe nasal drops is if it's a fracture without dislocation, our patient can feel nasal obstruction. But if it's a fracture with dislocation, of course, after removing the spleens or a piece of gauze from the nasal cavity, this piece of gauze we have to put inside the nasal cavity to suppose nasal bones not to dislocate again. Of course, we have to prescribe nasal drops or if this nasal obstruction is present in a few months after nasal fracture, of course, we have to do X-ray and to see what's wrong with maybe nasal septum. Blowout fractures, extraocular muscle entrapment, and diplopia. Nasolacrimal duct injury due to the close relationship of the duct of the nasal bones. Fracture of the cribriform plate and cerebrospinal fluid rhinorrhea. Inability to reduce fracture that cannot be reduced by closed techniques are candidates for open reduction. And the next bone, it's a zygomatic bone and zygomatic arch. For fractures of the nasal bone, it's a zygomatic fracture are the second most common fracture of the face after nasal fractures, of course, and predominantly occur in males. And zygomatic bone is a particular the malar eminence plays an important part in the appearance of the face. It's a component of the lateral wall and floor of the orbit, as well as zygomatic arch. Moreover, it contains tiny holes, also known as a foramina, which allows for the passage of important neurovascular structures. Fractures of the zygomatic bone can extend through the structure suture lines, namely the zygomatica frontal, zygomatica temporal, and zygomatica maxillary. Furthermore, the lines of the fracture can also extend through the articulation that zygomatic bone has with the sphenoid bones greater vein, and also zygomatic arch fracture can occur and may result in comminuted fracture. According to the classifications, a lot of classification, as I said, for previous fractures of bones. And here, let's talk about zygomatic body or tripod fracture and zygomatic arch fractures. And another classification is Manson's classification of zygomatic fracture: low energy, middle energy, and high energy. And a few words about zygomatic arch. It consists of temporal process of zygomatic bone and the zygomatic process of temporal bone. Low energy fractures are those the direct result of displacement of the bone. This means that there may be a crack in the bone, but its alignment is not disturbed. Middle energy fractures are those that can moderate displacement and in some cases comminution. High energy fracture, for example, for maxillofacial area and for diaphragmatic bone and arch are those with a severe displacement and comminution. This is a splintering of the bone into the multiple fragments. Other classification systems are based on the site of the fracture as well as its degree of comminution and displacement, whether inferior, medial, medial and posterior. What about signs and symptoms of zygomatic fracture and zygomatic arch fracture? Patients with zygomatic fracture can present with a wide range of signs and symptoms depending on the kinetic force that cause the resultant damage. There will certainly be pain, limitation with regards to movements that are associated with the zygomatic bone. If there is associated injury to the orbit and ocular structure, might be localized hemorrhaging as well as a double vision. Patient may also develop trismus, its inability to fully open the mouth or even movements of the mouth due to the spastic reaction of the masticator muscle and have difficulty with the chewing. They may be also be bleeding through the nose, which depends on the severity of the injury. The cheekbone of this, and here you can see the patients with zygomatic bone fractures, and the cheekbones of these patients may be flattened due to the malar eminence being depressed, and you can see easily on this photo. There is a palpable step defect, and this step defect we can palpate along the infraorbital rim, lateral orbital region, and diagrammatic maxillary buttress. Furthermore, there is what may be referred to as the flame sign that arises as a result of the tender of the lateral centrum being depressed and disrupted. Patients may also report paresthesia in the areas that are supplied by the nerves and are affected by the injury. And let's see on this photo, you can see the, let's see on the maxilla and zygomatic bone. And inferiorly in the infraorbital rim, you can see a foramen. It's a foramen, infraorbital foramen, through what infraorbital nerve goes from the bone part outside to the soft tissues. And of course, due to the zygomatic bone fracture with dislocation, this area will be traumatized, and we can find open and closed wounds, and due to the nerve is pressed by edema, by trauma, by hematoma. Of course, our patient will feel some numbness or paresthesia of this area. And on this slide, you can easily understand why, due to the zygomatic bone fracture with dislocation, our patient can move the lower jaw, because when it's dislocated on the inner side, it will block movement of coronoid process of the mandible, and of course our patient won't be able to move the lower jaw. And on this slide you can see a symptom of the step, and we can see the blood inside the sinus, or level of the fluid inside this maxillary sinus, and it will be zygomatic bone fracture and maxillary fracture with dislocation, of course. On this CT, it's visible air fluid level and the bone of the zygomatic fracture, sorry, of the zygomatic bone. And about treatment, the same. Our patient will require reduction if it's a fracture with dislocation, and fixation. If it's a fracture without dislocation, only fixation will be enough. What about reduction? The same, closed reduction and open reduction. According to the closed reduction to the zygomatic bone and arch, you can see, and I try to explain you different ways, but All of these techniques, it's closed reduction techniques. And most widespread techniques, it's a bone hook. We have special hook named after Limburg hook, and we have to put it through the skin, muscles, fascia under the zygomatic arch or bone, and then pull out the zygomatic bone in its right anatomical position. The same aim of the screw and traction and threaded reduction tools. We can use these screws which is inserted into the zygomatic bone, and this allows fracture reduction using the screw and holding instrument, and we can tract. If by the bone we can only take it out, zygomatic bone, but if it's, for example, fracture and dislocation with traction, or reversing, we can use this screw and tract it in right anatomical position. And the same threaded reduction tools, we can use Caro-Gerard screw, which is inserted inside the zygoma and then put out. And the next question is, how can we understand if it's successful or not? Of course, you can say that we have to do X-ray or CT and be sure, but in our operation rooms, we have no CT and X-ray, and it will take time in order to understand. And we have understand immediately after our, for example, bone hook reduction. Of course, I hope that you remember about clinical features of the zygomatic bone fracture with dislocation. First of all, it's a symptom of step, which we can palpate along the infraorbital rim, and it's unable of opening the mouth or movement of the lower jaw. And if our procedure is successful or our close reduction is successful, we have to palpate infraorbital rim, and we won't find a symptom of the step, because the zygomatic bone will be on its right anatomical position, and even after edema we can easily palpate it. And the second, we have to ask the patient to try slowly and easily to open the mouth, to open and close, and then try to move it from side to side. Of course, easily and not by force, and after a few minutes our patient will easily open and close the mouth. He can move the mouth, and of course this movement and palpation will say that our reduction was successful. And what about open reduction? Of course, if closed reduction was unsuccessful, or maybe it's we can't use closed method or techniques of reduction. We have to do open reduction techniques, and it's a surgical treatment, of course. On this slide, you can see different plates, mini plates, which we can screw on the broken parts of the bone and connect it together in its anatomical right position. And on this slide, you can see scheme of open surgical treatment, and you can see screw and bone grafts, which we can use in order to help of bone healing. Here it's a patient with a zygomatic arch fracture, and you can see deviation of the zygomatic bone and arch area, and we can see a ecchymosis, and on CT we can see lines of the fracture. And the last question for today, it's a maxilla fracture, most difficult fractures. Classification of most widespread classification, which is used in all over the world, it's Lefort classification. it's not a classification for practitioners because it's not useful for us because it's a symmetrical classification, and there are a lot of cases of asymmetrical fractures. But in order on in borders of lecture, we'll talk about Lefort classification. Lefort first, second, and third classification. Third point. Lefort first level fracture, and on these photos you can see the four first or lower are essentially separation of the hard palate from the upper maxilla due to the transverse fracture running through the maxilla and pterygoid plates at a level just above the floor of the nose. The fracture lines of the 4-1 may be a line as simple or comminuted complex. And here you can see this type of fracture signs: it's malocclusion, buccal ecchymosis, epistaxis, maxillary crepitus, maxilla mobile, and you can easily put it by fingers and try to move, of course, easily, and will hear crepitation, sounds of crepitation, and feel it under the fingers and see the movements of the maxilla. And you remember the maxilla is non-movable jaw, and if we can move it, that means that it's a line of the fracture. And here you can see the same line of the Lefort one or first fracture, and we can see the blood inside the sinuses. Lefort second is also known as a pyramidal maxillary fracture. These fractures transect the nasal bones, medial anterior orbital wall, orbital floor, orbital inferior orbital rims, and finally goes to the posterior maxilla and pterygoid plates of sphenoid bones, of course. And here you can see the patient with the maxilla Lefort second fracture. It's a deviation of upper teeth, mid-face crepitus, facial lengthening, swelling, and edema, bilateral epistaxis, tip of defect, and arterioorbital rim, infraorbital paresthesia, and ecchymosis. Of course, we can't put a diagnosis without any CT or X-ray. We have to do this is investigation. And here you can see X-ray. I try to find X-ray with Lefort 2 unilateral fracture. And as I said, all Lefort fractures classification, they are symmetrical, and if it's unilateral it can be Lefort, but in order you to understand better, I'll show you this one. And third Lefort is also known as a craniofacial disjunction because the entire mass of the facial bone is separated from the cranial base. This is the highest level of Lefort fracture and essentially separates the maxilla from the skull base. The fracture is transverse separation of the nasal frontal structure, medial orbital wall, lateral orbital wall, or zygomatic frontal structure, zygomatic arch, and pterygoid plates of sphenoid bones. And here you can see investigation of the evaluation of the patient with Lefort third fracture, and the next it's a CT for Lefort third fracture. And of course, main question is treatment. How can we treat it? Because if the maxilla, we can fixate to the if the mandible, we can fixate to the maxilla. Because movable, we can fixate to the unmovable. But what can we do with the maxilla? It's unmovable. And to what bones or parts of the bone we can fixate in order to help of the healing process? Of course. Here we can use different ways of fixation, and usually it's extraoral fixation, and usually it's open reduction techniques. And here on this slide you can see mini plates. As I said it earlier, to all other bones, mandible, zygomatic, nasal, and we can use it easily to the maxilla too. And on the next scheme you can see wirings. We can use special screws which we can screw in the, for example, mandible and maxilla, and to the zygomatic bone and zygomatic arch, and even frontal bone, and then use special ligature, how to say it, ligature or wirings on this screw, which we can use through this arch, for example, as you can see on the scheme in the below part of the slide. Due to the wire the maxilla to the upper side of the cranium or other non-movable parts of the cranium. And here you can see external fixation, and it's usual for the maxilla. And in the Second World War, we, I said we, not we, as maxillofacial surgeons, used external fixation, but of course this external fixation has a lot of disadvantages. And the first disadvantage, it's necrosis of the soft tissues. And scar formation after this necrosis, and even without this necrosis, scar formation. And but these disadvantages, of course, we won't see on them, because we have to treat a maxillary fracture, because it life-threatening situation, and we have to do something for our patient if open reduction is unsuccessful or impossible. And that's all for today. I hope it was interesting and understandable lecture. Next time and last time we'll see in 2 weeks in the same time. Thank you for your attention, and goodbye.